Our next speaker is our distinguished pathologist, Dr. Ari Mohammed Abdullah, who has a master's degree in pathology and a Kurdish board in histopathology and cytopathology. He's our pathologist who signs out and sees all of the thyroid and breast cases. So he has a pretty good experience with that. He'll focus on what to keep in mind or what to consider prior to ablation that is of relevance to us pathologists. So I'd like to welcome Dr. Ari to the stage.
Thank you. Good morning, everyone. Actually, my talk will be on both thyroid and breast, although the section that I was in is primarily on the breast, but I will talk maybe on the breast and a few on the thyroid. I will not go in detail and regarding the consequences of the ablation. As you know, in almost every kind of ablation, the outcome is the same. It's the necrosis of the tumor and the cells in the area. And these kinds of the necrosis will start at the moment of the start of the ablation, and it will peak in about 6 months. And the end result will be total necrosis of the area, hopefully, and will be mostly it will be replaced by the fibrosis and some kinds of the regenerative change in the tissue. So my talk is primarily on what to have on the table before sending a patient for the ablation, in cases of the breast and in case of the thyroid. So the question is that, to do ablation or not to do? We will start by a case scenario, and I will ask you a question, and at the end of the presentation, I will try to get the answer from you. We have a 32-year-old female with a circumscribed breast mass for the last 3 years duration, and recently increased in the size by 10%. By an expert breast sonographer, it was assessed to be a U3 breast mass in the BIRAT category. You will offer for her to do surgery as the mass is increased and the age is above 30, but she refused surgical intervention and she heard something new about the ablation, and she wants to proceed for the ablation. Then, as a part of the management, you will send her for the core biopsy, and the core biopsy showed fibroepithelial lesion. Keep in mind, this is fibroepithelial. What's written on the surgical pathology report is that it was diagnosed as the fibroepithelial lesion with increased stromal cellularity and notable mitotic activity up to 4 mitosis per 2 millimeters square. And the pathologists say that he or she is favoring cellular fibroadenoma. This is not definitive diagnosis. The pathologist is favoring cellular fibroadenoma, and the age of the patient is 32. Would you recommend ablation as a treatment of choice, or you prefer surgery? So, any case of the who is planned to have ablation is like climbing a ladder. You'll start by the clinical, later on by the radiological assessment, later on by the histopathology, either in the form of the biopsy or in the form of the cytology. At the end point, either you'll climb the ladder or stepping down. Most important point in cases of the pre-ablation is to have a good and perfect radiological assessment, which is regarded as a gold standard for any cases of the ablation, because it ensures the accurate and effective management and treatment planning for the patient. And primarily, we have so many modalities used for the assessment, but I will talk on basically on the ultrasound, mammography, and MRI. As in the breast, ultrasound, mammography, and MRI it's the gold standard, while in the thyroid, ultrasound have the highest application. biopsy or cytology. This will depend on the targeted organ that you will plan to. For example, in cases of the breast, the preferable method and the standard of care is the biopsy. You should avoid cytology in any cases of the breast for the assessment, whether to ablate or not to ablate. It will give you the risk assessment, whether this tumor is benign or malignant, or let's say it's in the low risk category or in the high risk category. And it can be used as well for the post-ablation follow-up of the patient and monitoring. So in cases of the breast, no decision should be made on the FNA. Whatever when it's available, it is better to avoid final aspiration by every means. Core is the standard of care, and either almost it will give you in about 95% the exact diagnosis. So some corneal needle biopsy basics everyone should know is that we have a variety of radiological guidance method, which is available in our localities: ultrasound guided and stereotactic biopsy guided, while MRI, to my knowledge, is not available in our locality. A variety of needle size can be used for the core biopsy, with or without vacuum assistant. Luckily, right now in SMART we have a vacuum-assisted biopsy, which provide more detail regarding the area which have been biopsied. Usually, they use 14 gauge needle or 16, but in cases of the vacuum-assisted, we will use 11 or even 8 gauge, and this is a tissue on the slide taken by the different gauge biopsy, just to have imagine the amount of the tissue that can be harbored from the 40 gauge compared to the 11 gauge and compared to the 8 gauge core needle biopsy. Definitely, the one with the larger needle, it will make better it will be better for the assessment. One important point in any case of the ablation is to have a radiological pathological correlation. Not every case of final pathological report is definitive for the ablation. Sometimes there is concordance and sometimes there is discordance between the result of the imaging and the pathological report, either in the form of the cytology or histology. اما سمارت اشتاق معناها ام دي تي همو كات او ام دي تي كاين بو حالته كان جاري وهي ديسكوردانسيك معناها لبيني كور بايبسيكا راديولوجيكالي دكتور لانا اسسمنتي كدوا مثلا بايرادي شاتي وال هيستوباثولوجيكالي ام بايرادا فرقي هي ام اميك دايغنوستيك معناها فرقي هي لبرو كون او كورداسا زور مهمه ابي باثولوجي وراديولوجي بيكو دائما ميتيني شان هبه by somehow. For example, a circumscribed mass on imaging core biopsy shows fibroadenoma. This is concordant. Well, we have, for example, spiculated mass. Core biopsy showing lobular neoplasia in the form of the classical lobular hyperplasia. So this classical lobular carcinoma in situ, this classical lobular in situ will not explain this spiculated mass. So this biopsy should be regarded as a discordance. بلا محاولتش معناها يعني whatever you do, the biopsy result is hazy. For example, we have a vague area on MRI. The biopsy tells you that this is for example, PASH, pseudoangiomatous stromal hyperplasia. In this situation, it is better not to proceed for the ablation, as your result of the biopsy by itself is hazy. It's not black, not white, it's in the gray zone. So we are not preferring to do ablation when the result of the biopsy is coming back as this. For example, atypical ductal hyperplasia, it could be low-grade DCIS. When we say atypical ductal hyperplasia, in case of the core biopsy, it is better to proceed for the excision and not sending the patient for the ablation. When we say it is mammary carcinoma in situ, we are not sure about whether it is DCIS or LCIS. In this situation, avoid ablation. Papillary lesions, this is very important because papillary lesion could harbor areas of the atypia, or even when we say atypia, atypical ductal hyperplasia, or even sometimes can be involved by the DCIS. So in case of a large papillary lesion, it is better to think twice before sending the patient for the ablation. Any spindle cell lesion of the breast is better to avoid ablation. Why? Because spindle cell could be carcinoma. For example, we have fibromatosis like breast carcinoma, which is a kind of metaplastic carcinoma, and could be stromal in nature. So it is better to avoid this, to avoid these kinds of the patient. We have also columnar cell lesions with the atypia, which is known as the flat epithelial atypia. When you see this on the report, it is better to avoid ablation. Any fibroepithelial lesion which is not definitive. When we say sometimes بعض pathologists say, and we say fibroepithelial lesion, لبيني قوسك fibroadenoma. This means that this is fibroadenoma. بلام وكو تيرميك بكاريان. بلام when they say that this is fibroepithelial lesion favoring adenoma, معناه there is some chance to be not a fibroadenoma. لو معناه أما phylloids benign phylloids. So when we say fibroepithelial, it is better to avoid and at least to present the case in the MDT, which contains the pathologist and radiologist to discuss for the proceed or not to proceed. Vascular lesions, sometimes, for example, and la biopsy حتى say that there is endothelial cell proliferation, could be endothelioma, could be angiosarcoma. These kinds of the tumor, which cannot be the diagnosis not ready on the table, you should avoid ablation. أمانة بوشي مهم شو كتو جاري وياهن upgradeable, upstageable. Upgradeable شو مثلا تو atypical ductal hyperplasia وهي لكورا بلام أشي تستر إكسجينكا DCIS تها invasive tumor تها. That's why it is better to avoid the ablation and proceed for the excisional biopsy. So, papilloma on core biopsy, mostly it will be benign. Balam atypia and malignant papillary lesion is sometimes very difficult to be differentiated on coronal biopsy alone, and needs excision for the assessment of the entire lesion. Why? Because sometimes sampling issue is we have what's called sampling error, not technical error. Sampling error, you will take the sample from the area which not harboring the atypia or the DCIS. Okay, thank you. This is a bunch of research by many authors regarding the papilloma, the excision, the number of the excision of the papillomas, the rate of the upstaging after the excision. أمانان بكورة، أمانان بأبستaging. You'll see that the range will range of the upstage will range from the 0 to even 34, to even to 9%. يعني to occur the كورة بأبسكت أوبت benign be هي benign papilloma بلام دوائل excision up to 9% of them could change to the atypia and malignancy. Okay, I'll skip this, and I will talk briefly about thyroid. And thyroid assessment is primary by ultrasound. In case of the thyroid, we will not do core, we will do cytology. So the preferred method is different according to the target organ. The cytology, we will use a Bethesda system, which gives you the risk of the malignancy exactly according to the each category. Basically, أواني كنا diagnostic نشرني هم يعني أوميت كي أبي أوش لقال وكنت معن أبي pathology radiology conference كبي كباسكرة. For example, radiology say that this is a cystic nodule, totally cystic nodule. Aspiration done, preparation for the ablation. You will see that this is inconclusive. On which base? Because it only contains cystic content. لو حالتها بيوز نكتو بيدو باريكيتو. Non-diagnostic. You can proceed for the ablation in the form of the ethanol ablation. Okay. Not to do ablation in two, actually. Yeah, Bethesda C, which is atypia of undetermined significance. Yeah, Bethesda Chuar, which is suspicious for follicular neoplasm or suspicious for oncocytic cell neoplasm. Otherwise, the Bethesda Yeka agar totally cystic be, le Bethesda dua ka benigna, le Bethesda Chuara penja ka suspicious for PTC, le Bethesda shishaka PTC microcarcinoma, you can proceed for ablation. Esagreno bo amkisa al wika bas mankelt to amkisa an yaribu ablation yana.
I will never do ablation and treatment surgical because if you read the history, this patient was having increase in size and the ultrasound is lucid and your biopsy is favoring cellular fibroadenoma.
Yes, favoring. This is the point. يعني أول كاكتور.
I will do the second biopsy, core biopsy.
Yes. Not core biopsy. You may proceed for the vacuum assisted or excisional biopsy. Yes.
Nowadays,
Yes.
the vacuum is more sensitive than
Yes, it's available right now in smart. So I would do terms dormi, cellular and favoring, which is not definitive. أوش راسبك الله ورحماني عزيز قلتوا معهم وسباس.
That's what thank you, Dr. Ari, for your nice presentation and the pertinent points. As you highlighted the importance of MDT discussions of cases